Our next speaker, who is sponsored by the McKay Surgical Center and Orthopedics, will be Michael Bullard, who will be speaking on what's new in pediatric ophthalmology.
I'm right here.
And there he is, right behind me. The time is yours, sir.
Okay. All right, well, thank you for having me. I'll add to Dr. Anderson's lecture, he forgot to mention the eye benefits of treating sleep apnea. So there's less glaucoma and less ischemic events to the optic nerve. So you might want to add that to your slides because that's the most important part. I'm just joking. So I'm excited to be able to come talk with you. As I was preparing for this talk, I was thinking back to my when I was a medical student, and I actually was sitting near the front row, right in the middle, and I fell asleep in the middle of the lecture, and I got berated by the presenter about falling asleep. And my friend looked over at me and said, "Man, I hope you're not planning on going into ophthalmology." And here I am. So if you fall asleep, I won't be too upset. I've been there. So I've chosen to speak about just a few things that are new and some things that would be of interest to primary care providers in kids in ophthalmology. So let's see if I can do it like this. So the first thing I wanted to talk a little bit about is myopia. So you might think this is pretty boring. Myopia is nearsightedness. There's probably many of you, I see glasses in the audience here, and many of you have myopia. And you may not think of it as a big priority. However, if you look worldwide, there is a large increase in myopia in the world today. It's as high as 50% in some regions of the world in kids and 95% in some areas of the world, mostly over in Asia. And if you've ever been to anywhere in a third world country, I was over in Africa and Cape Verde doing a project over there, and it's amazing to see somebody who's blind just because they have no access to glasses. That was actually when I went over there. I went over to do a medical mission to teach some doctors how to do strabismus surgery. And what I found out is one of their biggest hurdles to healthcare, to eye care over there, is just getting glasses to their patients. And that's been something that was eye-opening to me. And it's actually been added, as you can see here at the bottom, it's one of the conditions targeted by the World Health Organization for their global initiative to prevent and eliminate blindness. So this is that boring slide you'll remember from when you were studying ophthalmology, but the nearsightedness has to do mostly with the size of the eye from front to back. So from the cornea here to the back to the fovea. And when you look at a myopic eye, the eye, and it's a little subtle on this slide, but the eye is actually longer from front to back. We call that axial length or axial myopia. Now, a hyperopic eye or a farsighted eye is actually shorter than normal. And astigmatism has to do with the overall shape, the roundness of the eye is not normal. And so besides just needing glasses, besides just being a glasses problem, severe changes in axial length, a really long eye, can cause degeneration of the macula, similar to what you get in macular degeneration and some of the complications that we get in macular degeneration. And so people who get up into these higher numbers of nearsightedness can have severe problems with their vision as they get older, and it's another reason for us to want to treat this. Unfortunately, there hasn't been a lot of good treatments to prevent axial lengthening. We give people glasses to treat their vision, to allow them to see better, but putting them in glasses or not putting them in glasses actually doesn't have much, if any, effect on the growth of the eye over time. And so there has been an initiative out there to try to find therapies that can prevent the eye from growing so big. So one thing that's been out there, and this has been around actually for a little while, is called orthokeratology. And what they do is you put a contact lens on the eye that they wear while they sleep, actually. And you wear it all night long, and then you take it off in the daytime, and then your eye has been kind of warped into a different shape, which changes the way it refracts the light and can allow you to see without glasses or contacts during the day. Now, some adults do this just to avoid having to wear contacts or glasses during the day. But they've also been using this in kids to see if it will change the way the eye grows and prevent myopia. And in some studies, it's maybe shown some minimal benefit. However, as you can see on this bottom slide, here's the big downside. So this is a big corneal ulcer. And corneal ulcers are a bad deal, especially in a developing young child. And if you get a corneal ulcer that's this size with this amount of infection, you're probably going to end up with permanently decreased vision, if not legal blindness in this size. So to me, this is not a great option. I don't prescribe this, but it's out there, and you may hear about it a little bit. Here's another one that's been around for a little while that people have been studying. We use atropine eye drops. You may all be familiar with atropine used for other things, but atropine in the eyes is something that we've been using for treatment of amblyopia for some time. And this is a child that's being treated for amblyopia. They put atropine in their left eye, and that penalizes that eye, makes it hard for that eye to focus so that they have to use their right eye. The problem with atropine is that it's in the United States right now, it's only available in 1% drops. And 1% drops give you a lot of pupillary dilation. They also paralyze the accommodative muscle of the eye, the ciliary body muscle of the eye, which makes it so you can't focus at near. Now, that's how we use it to treat amblyopia. But if you put that in both eyes, you essentially make the kid wear bifocals as a young kid because they can no longer see up close without using a bifocal. And it also, there's a lot of light sensitivity associated with it. And so despite there being some benefit in some studies, this has not been a popular option with most of us because it's just too much side effect on the profile. But now there's a new one, atropine 0.1%, which is actually been shown to be maybe more efficacious, actually have more of an effect on axial lengthening over time, and yet it doesn't have any of these side effects. And so this is something you can see here. It's actually available outside the United States now. It's being made in the United States. We have to get it compounded, but I think this will be coming soon. And the effects are mild, but if it can help overall, this might be something that'll be very useful. I think this is going to be coming soon. This is kind of an interesting one for our primary care providers because this is something that you can really do. A recent study showed that actually the amount of time spent outdoors has an enormous effect, or has some effect at least, on axial lengthening and on the development of myopia. A lot of people have the theory that the reason why we're having more myopia now is because we're spending so much time looking at things that are close to us, and that's making us nearsighted, a predilection for near. What was interesting in this study is they randomized some people to doing a certain amount of near tasks, but doing them outdoors instead of indoors. And what they found is that there was no effect of the amount of near work being done, but there was actually the effect was only found in the amount of time that was spent outdoors. So not that we need really much more evidence in getting our kids outside and having them be active and be outdoors, but this is another reason that we can really urge kids to be outdoors. It's good for their eyes. Okay, we're going to switch gears a little bit here, and I'm going to talk a little bit about congenital nasolacrimal duct obstruction. So those of you who take care of kids, and especially kids under the age of 1, will be familiar with this condition. It's a condition that the onset is really at birth, but the symptoms sometimes don't show up till about 2 to 3 months because the eye doesn't really make a lot of tears until about 1 to 2 months of age. So a lot of times parents don't notice it right away, but it comes on a little bit later. And conservative treatments, we'll have the parents massage here in the corner of the eye, the nasolacrimal sac here. Sometimes we'll use some antibiotics topically to help treat a superinfection that can sometimes happen. The good thing about this condition is that it usually resolves on its own, and by 9 to 12 months, depending on what study you look at, about 70 to 90% of these will go away on their own. The treatment, if they don't go away, is to do this nasolacrimal duct probing, and this is a slide that shows you how it's done. You insert the probe, this is the metal probe here, you insert it into the puncta, or the opening in the eyelid where the tears are to drain. You put it through the canaliculus over here into the nasolacrimal sac, and you can actually feel it touch up against the bone. That's how you know you're in there in the right spot. And then you turn it 90 degrees, and you actually put the probe down all the way through this bony canal, which is the actual duct, is this part here, and the obstruction is usually down here at the distal duct. And it's usually just a little membrane of tissue. It's not hard to break through. You can kind of feel it as the probe goes up against it, and a little just gentle pressure, and you can pop through that membrane. And you can see here this child is under anesthesia and has this probe. It kind of looks strange, but it's going down through the nasolacrimal duct, and then he's using this second probe to confirm that it's popped all the way through under the inferior meatus, and you can feel metal-on-metal contact. It's hard to see this, so you kind of do it blindly, but you make sure that your probe is where it should be. This is just a quick video. I just want to show part of this. Let's see. I went to the University of Iowa for medical school, so I do this very similarly. And this guy puts his videos up on YouTube, but this is not turning on. Can you play that video there? Maybe not. Okay, let's see. The intro wasn't too long, so I don't think it's playing. We can skip it if we need to. Yeah, can you hit the play button at the bottom there? When you move the mouse, oh, there it goes. Okay, so now you can just see this being done. That's a punctal dilator. It's going in through the puncta there, dilating that up so that the probe will go in. There's a punctum on both the upper and lower. Here's the probe going in. You extend that over towards the nose. Here he's going in the upper to make sure the canaliculus is open. We inject fluorescein in there to see, right now he's injecting that to see if it'll go down into the nose. And if you look closely, you'll see it's all pooling up in the eye here. So it's, oops. Oh, now I messed it up. Sorry. Anyway, you'll see it was pooling up there in the eye. That confirms the obstruction. We'll just go on to the next. We can go on. We can skip that just for time's sake. It's pooling up there in the eye, so it's obstructed, and you take that probe and just turn it 90 degrees, and you'll relieve the obstruction. What's new, that procedure is not necessarily what's new, but what's new is the understanding of when these things need to be probed, when they need to be treated, and how to do that. So you'll find some providers that will do this treatment before 6 months of age. They'll actually do it in the clinic. You bring the kid in, you can papoose them up and hold them down and put the probe in through the puncta, and you get kind of a one chance to go in and relieve the obstruction. I'm not a huge fan of that for a couple of reasons. One, it's super traumatizing to the parent if they demand on being in the room. It's traumatizing to the child. It's traumatizing for the nursing staff as well. They don't like it very much. You can do that, but the main reason is that at 6 months old or younger than that, most of those are going to go away anyway. So you're treating a lot of people who don't need the treatment. The downside to doing it later is that you need some anesthesia. I do it under anesthesia, but normally it's very minimal anesthesia. The procedure takes 5 to 10 minutes. You can do it pretty quickly. What's new though is I keep doing the same thing, is that there's new evidence to suggest that we need to be doing this before 15 months of age to make this its most successful product. If you do it before 15 months of age, the cure rate is above 95% for this procedure, given normal anatomy. If you get in there and everything is normal and you just have a normal membranous obstruction, then the cure rate is as high as 95%, and that goes down steadily as you get older. When I do these in 3 or 4-year-old children, the success rate with a simple probing is probably more around 50%, and so it goes down quite a bit. And so getting these kids in and getting them treated quickly can be a big benefit. I wanted to speak real quickly also about amblyopia and what's going on with amblyopia treatment. We won't go into this a lot, but amblyopia is essentially when you have a physically normal eye that's not seeing up to its full potential, and that can happen for multiple reasons. The main one being just the kid needs glasses. They have an asymmetric prescription in the two eyes, so the two eyes are never in focus together, and the pediatric brain does not handle that situation very well, and it will lead to amblyopia. And our treatments and our current treatments are mostly patch therapy. That's what I do the most of, is we patch these people. We don't do full-time patching anymore, mostly just part-time patching. We have atropine. We talked about that, glasses when they need them. And we have to do this young. But this is kind of what most kids think about patching here. I like this picture. I found this on a colleague's slide. Kids hate amblyopia treatment. I mean, it is a struggle. It is a battle. I mean, I congratulate parents when we finally graduate them from the amblyopia treatment, because they just do not like that. We're coming to understand a little bit more about amblyopia. We used to think, because of early animal models where we completely disrupted vision in an animal model at birth, that there was that the development of the brain in those areas of vision were immature, and that is what happens if you completely obstruct visual development at a very early age in the first few weeks of life. We know that from cataracts. A pediatric cataract that's significantly dense needs to be removed before 6 to 8 weeks of life, or else it's permanent blindness no matter what you do after that. However, most amblyopia is not that severe, and what we're coming to find out is that those pathways of the brain are actually mature and they're there, but they're being actively suppressed. And this changes the game, because if we can somehow eliminate the suppression, we don't have to make the brain grow those pathways. We can actually just eliminate the suppression. And so that's exciting for hopefully future treatments for adults with amblyopia, because this is one of the major causes of unilateral blindness in the world today, even in the United States, is untreated or undertreated amblyopia in people that are now adults. And there's some different treatments that are coming out for this too. This is one that I'm kind of hoping comes out, because I've always wanted to tell my kids that I'm going to prescribe them video game therapy, because then I'd be like a hero instead of the villain. But there are some new treatments in amblyopia therapy where they're taking glasses that have these filters on, and red and blue filters. They wear the glasses while they play a game, and you can change the way they see the game. They see certain parts of the video game depending on whether the red or the blue light is being used, and you can actually use that to treat the amblyopia by keeping both eyes open and having them do something that's a little bit more fun. So this is still kind of in the works. We're not sure how well this is working yet, but this is coming as well, hopefully. I wanted to give just a quick shout about pink eye. Okay, everybody in this room that takes care of adults or children in the primary care setting deals with this. And this is not necessarily totally new, but there's more and more data coming out that we are over-treating pink eye, or what pink eye I'm saying here is conjunctivitis, infectious conjunctivitis. A lot of what we think is infectious conjunctivitis, especially if it keeps coming back, is actually this condition called blepharitis, and you can read about this. This is my least favorite thing in the world, but up to 60% of patients with infectious conjunctivitis are getting antibiotics, where probably, and it's hard to say, but probably 90% or more of infectious conjunctivitis is viral. And just like we used to treat every cough and cold, or we used to treat a lot of those with antibiotics, and now we just say you have to run its course, the same thing goes with treatment of of infectious conjunctivitis. In fact, about 98% or 99% of bacterial conjunctivitis will resolve itself with no treatment within 3 to 5 days. And actually adding antibiotics may or may not speed up the recovery for our patients. And the problem with this is in ophthalmology, as well as in anything else, are the incidence of severe infections that are resistant to bacteria or resistant to our antibiotics is increasing, and people are not necessarily making a whole lot of new antibiotics. So this is something that is important. If we can limit our use of antibiotics to the immunocompromised contact lens wearers, we can improve this situation a lot. And so I'd urge you to think about that heavily. There really aren't very many conditions that putting them on antibiotics as a prophylaxis is going to help. If they're a contact lens wearer and they're having severe eye pain and an injection and stuff, they should probably be in to see an ophthalmologist anyway. So urge you to think about that in the way you're prescribing that. Bacterial conjunctivitis, if it's really severe, it is going to have a pus-like discharge. You'll see it. It is nasty. It is really gross. The yellow, green stuff that gets on the lashes, that's usually viral. When you look at the child or look at the adult, they're going to have mostly a clear-looking discharge, and that is almost always viral. In fact, I have not prescribed antibiotics for conjunctivitis in probably over 3 years, to tell you how little I do that. I just have to talk to the patient and say, look, this looks bad, but this is going to get better, and you're going to be fine, and it's better if we don't treat you with antibiotics. That being said, I have seen allergies from antibiotics being used for conjunctivitis probably 3 times in the last 2 weeks, that I've had to stop the medication and say, look, the virus is gone, but now you're just having a reaction to the drops you're using. So, all right. And I think we'll end here probably just with this. This is just really interesting. This isn't super new. Some of you may be coming across this already, but capillary hemangiomas of the skin in general, but of the eyelid in my case here, these are not only cosmetically very noticeable, but they can cause astigmatism of the eye, which can lead to amblyopia, and they can actually occlude vision if they get big enough and they cover the pupil. Then that eye doesn't develop vision, and we get amblyopia from this. And this has been historically kind of a difficult thing to treat. We've tried to excise them. We used to inject them with steroids, which obviously has some side effects to it. And so this has been something that's been somewhat difficult, even though some of the results were pretty good with older treatments. But what's interesting is that somehow somebody figured out if you give a kid oral propranolol, you can make these things go away. And here are some before and after pictures of these. This is a deeper one that you can kind of see here. And you see after the treatment, you can't even really tell that it's there. Here's one that's a little bit more superficial, a little bit more obvious. And after the induction of oral propranolol, you can say it's almost gone. And this is actually within weeks of the treatment, you see the change, the difference. And it's really remarkable and kind of fun to see these. And it's getting easier to do. We used to have to put patients in the hospital and monitor them, cardiac monitor them, and do some things. And it's becoming more and more safe and the way that we're dosing these. And so this is becoming easier to do, and it's a good treatment for those. My last little blurb I'm going to put in here, and I don't have time to go through all of this, but as a pediatric ophthalmologist, actually a lot of what we do is treat adults with strabismus. And you might not think of adults as needing strabismus treatment, but I think all of us probably know somebody who has this look to them. And the piece of information that's out there is that it's too late for these people. They had their chance when they were kids, and now you can't do anything for them. And that is actually absolutely wrong. There's a big initiative by the American Association of Pediatric Ophthalmology and Strabismus to get the word out there that these patients can be treated. In fact, they can be treated quite well. And there's a lot of benefits to it. Not only do they, the patients that come in with that problem are the ones that have double vision. They come in, they seek treatment, and we can get rid of their double vision a lot of times. That's the easy one because they usually seek treatment on their own. But the others that had childhood strabismus who don't see double vision, they get improvements in their visual field. They restore binocularity and their depth perception improves. It improves their driving safety, obviously their self-image, and there's been multiple studies to show that there's less depression, less anxiety. There's actually one of my favorite ones was this study, which they actually took normal people and they photoshopped their eyes to look like they had strabismus, and they put them in the job pool for a job, and it was actually proven that this guy who has the same resume exactly as this guy and this guy was the one that gets the job. And these ones, especially in women, were less likely to get the job. Some of my most appreciative patients are the adults that come in with this problem, and we can help them look somebody in the eye again without them having to be self-conscious, and that's something we love to do. So thank you for your attention. Hopefully that was somewhat useful. I'll take some questions if you have them. Good, no questions.
We have one question. She's running to the mic.
So I feel like we treat pink eye not for the patient, but for the daycare or the school. How do you get the kid back in school without antibiotics?
That's a good point. So the first thing to say is that antibiotics do not do anything to get the patient back into school. So you're actually sending the person back to school while they're still very contagious. And so that if you had more time, we could go into that. But yeah, we should be keeping those kids home from school, home from daycare, until their redness and until especially the discharge has improved. Putting them on antibiotics does not prevent the spread of infection. And especially since 90-something% are viral, you're just putting them back into the pool with all the other kids. And some of the viruses can actually stay active on a dormant surface like a doorknob or a desk or something like that for up to 48 hours. So they can touch their eye, touch a doorknob, and every person that comes by for the next 48 hours, if they get enough of that, can get that virus. So that's a good point. But I think it's a big problem in our daycares, especially because we have trouble sending people back when they're actually cured, because the daycare says, well, they need to be on antibiotics. And we said, well, no, they don't. They actually need to be. That needs to have resolved, and once it's resolved, they can go back. Good question.
Well, thank you very much. That was a wonderful lecture.